Thank you
Yes,
so
sure,
much
sure.
for all your cooperation. So we're going to talk about, managing glaucoma in these atypical high myopia cases, which we are constantly finding. And we know that myopia and glaucoma coexist, and myopia is also a growing public health problem. Younger age being affected, Asia, and then followed by the West. And glaucoma, as we know, is a leading cause of irreversible blindness, affecting more than 100 million people. And both of them may coexist, and the glaucomatous changes in such eyes are very difficult to detect and resulting in overdiagnosis or underdiagnosis. In various population-based epidemiological studies, they have found that definitely high myopia is associated with greater prevalence, and myopia also has a role in the development of glaucoma at younger age. But clinic-based myopia studies have not glaucoma progression, possibly because it is very difficult to detect progression on structural or functional assessment, or maybe that the glaucoma has been misdiagnosed. As a result, there has been no progression whatsoever. Now, these are the traditional methods of diagnosing glaucoma in our patients. So let's come to one of my patients who has been under follow-up for high myopia and glaucoma for the past 11 years, of course, in different hospitals. What is important is that father had glaucoma. Her myopia was approximately 16.50 in the right eye, and left eye was 14.50. Her pressures were 17 and 16 in 2010. Her CCTs were in 544 and 541, gonioscopically open angles. And as per her notes, she had possibly had some nasal defects in the right eye. And they thought maybe it is myopic. Left eye was normal. She underwent LASIK in 210. At that time, her CCT reduced to 399 and 407. And in 2014, she was put on anti-glaucoma travoprost and timolol. Now, if we look at the traditional methods, that is intraocular pressure, 3 years I've given 3 pressure readings, which we find were practically normal. But we know that intraocular pressure is higher in patients of high myopia with glaucoma. So we must do a good diurnal variation. Also, if we can take the basal pressures, we know that this is the basal pressure. And as the patient comes for follow-up, take this basal pressure and use it for comparison to know is the pressure rising or not. And in cases who have undergone, like for example, this patient keratorefractive surgeries, better to use ORA or other tonometers. Now let's have the look at the second thing, and that is the fundoscopy or the optic nerve heads, which show definite differences, can show also definite differences. So in 2014, if you look at the right eye, and again in 2019, if you look at the right eye optic nerve heads, you find that there isn't much change. So if you do serial photographs of patients also, that will also give us a good indication whether there are any changes taking place. If you look at the left eye also, we find that practically there was no change. But what happens, what are the difficulties in assessment of high myopia and glaucoma optic discs? Now, we find that in high myopia, there's a huge color contrast between the pink neuroretinal rim, which we normally see, and the pale optic disc. We find that this color contrast decreases because the neuroretinal rim pallor also increases. As a result, you can't make out the difference as to what is the neuroretinal rim and what is the optic cup. Also, the PPA, that is in cases which we see both in glaucoma as well as in cases of high myopia. In myopia, the PPA has the gamma and the delta zones, and it is very difficult to see by fundoscoping what is the beta zone of glaucoma vis-a-vis the gamma and the delta zones in cases of high myopia. Plus, there's a spatial contrast between the height of the neuroretinal rim and the bottom of the optic cup. And that occurs because there's flattening of the cup because of enlargement of and stretching of the optic disc and lamina cribrosa. So the contrast decreases. Again, we cannot make out clinically. Plus, the optic disc also may rotate. It may rotate vertically, it may rotate horizontally. But when it rotates vertically, it gives an oblique view of the optic nerve head. Then again, we always look at the retinal nerve fiber layer. But the retinal nerve fiber layer assessment becomes very difficult in the PPA region because of increased brightness of the underlying PPA tissue. Let's have a look at the left eye. Left eye, we find this looks glaucomatous because the neuroretinal rim is narrow, especially inferiorly. There is a lot of bending of the vessels near the disc margin, and the CDR is increased. We also have to remember that there can be a secondary macro disc which might appear in cases of high myopia. Now, we all know that, that the three layers, Brooks membrane, choroid, and the peripapillary scleral flange that is there, they are almost in one line. But when we have high myopia, the Brooks membrane gets pulled towards the fovea. And as a result, the Brooks membrane sort of overhangs this peripapillary scleral flange, resulting in the gamma zone. So I've shown the pictures of how a peripapillary, gamma zone, and the delta zone occur in cases of high myopia. And this is something that focuses the clinical assessment of both these conditions. Along with that, because of this flange which occurs, because this Brooks membrane sort of overhangs in the optic cup, and therefore our assessment of the neuroretinal thickness in OCT also becomes effective. Now, then the next thing that we always assess is the visual field changes. We have to assess, are they present? Are they because of glaucoma? Are they because of high myopia? So our patient, when we go back to it, 2010, 15, and 19, a 10-2 was done in 2 years, and the last year, in 2019, a 30-2 was done. But what we find that except for the small differences that are present all around the blind spot, no other differences have occurred. That means there has been no progression also of the patient on visual fields. But we must remember that in glaucoma, the visual fields are typically seen in the germ area, as well as we can see nasal steps. Fixation only gets affected very much later because of progressive enlargement, that is towards the end stage of glaucoma. And central visual field, as I said, can be spared till the last stage. But in myopic glaucoma, early central and paracentral scotomas definitely occur because of the papillomacular bundle occurring. Therefore, in these cases, it is always better to do a 24-2 perimetry and 10-2 perimetry, and always better to use a contact lens for these patients while doing perimetry to avoid the prismatic effects of the thick contact lenses. Now, there's another patient, 66-year-old male with high myopia of 17 and 14. And as you can see, that there's a lot of where the entire optic disc is almost pale, and the peripapillary areas in both the eyes, right and left, are very big, especially in the left eye. And you can see that the CD ratio is also approximately 0.6 to 0.7. Now, if you look at his fields done in September 2019, December 2019, again in 21, if you look at the MD, PSD, and the pattern deviation probability plot, practically no difference. Similarly, in the left eye also, practically no difference, therefore telling us that the glaucoma is not progressing at all. Now, therefore, it's always better to measure the structure and the function together. This is the key in the management of myopic glaucoma. We have more parameters to assess. Now we go back to the first patient. In 2010, she underwent straightest OCT, in which we find that the peripapillary RNFL was slightly thinned out, but the macular thickening was normal. If you look at the RNFL done in 2015, 16, and 19, it's better not to look just at the colors, but better to look at the numbers. If you look at the numbers, right eye in 2015 and 16 and 19, we find that practically there's hardly any difference in the numerical value of these particular segments. Similarly, in the left eye, if you find between 2015 and 19 that there's a huge difference. I will not go into details as to why these differences can occur. That is for another segment altogether. But if we have a look at again as the ganglion cell complexes of 15, 16, and 19, we find again differences are not very much, showing that there is no progression in glaucoma, which is very, very important for us to determine in these cases. Now, there are lots of difficulties in OCT imaging in high myopia because of poor fixation, because of development of posterior staphylomas, because of RNFL thickening, intracystic formation, abnormal retinal sloping near the disc margin. There can be RPE and photoreceptor loss. And as I've talked about, that the peripapillary atrophy also induces a misalignment of the disc as read by OCT. Therefore, another patient, let's say, we find that in high myopia, there's temporal shifting of the supero and inferior naso, the RNFL bundles, as we can see. And there can also be difficulty. We can use the GC-IPL for assessing change in glaucoma with certain limitations, of course, there. And does this patient have glaucoma? Does she need treatment? As per Robert Chang, yes, our patient had family history of glaucoma, high myopia, optic nerve is suggestive of glaucoma, LASIK both eyes before we treat. What do we do? Treat with AGM to low and the lower target, go for a lower target pressure. You can go for laser trabeculoplasty, do surgery, and trabeculectomy is very good. With one must pay attention to releasable sutures, mitomycin, and of course the risk of complications. There is something new which is coming up, normative data, including high myopia, normative data for the GCIPL, and also the ROTA, which is underway. OCTA still has to prove. So it'll prove its value. So let us see what we can do. We must recognize the problem and diagnose the problem. Thank you very much for your kind hearing.